This is Roxon Liu from Oakland, California, back with part four. I decided to split the mesh placement and the flap closure video since it was going to be too long in one video. So here you can see the defect closure was already done, and then I also closed the small hole in the peritoneum that I made when taking down the hernia sac. So my assistant is going to, my bedside assistant is cutting the mesh, rolling it up, and putting it in, so I don't have to scrub in to do this part. This is Covidian's Parietine mesh. It's a medium weight macroporous mesh. It's really my go-to mesh when I need a medium weight macroporous mesh. Um, I will also use a Bart soft mesh sometimes. This mesh was cut to about 15 centimeters by I think just a little over 20 centimeters to cover both the periumbilical hernia and the infraumbilical one. So because this mesh is a little longer, I decided to leave the fascial closure suture in place and use that to pin the mesh up. And I normally don't do that for the smaller meshes, like if it were 15 by 15. I really don't need to do this, but in this case, I decided to uh, save it to pin it up. The other way to do it is to just have the needle with a very short tail, and once you have the mesh up, use it to pin up the mesh. So the mesh is all rolled out now, and you can see it fits quite nicely into the space with excellent overlap in all directions. And I always try to make sure the mesh is laying flat in this space. If there's not enough room, it's pretty easy to create more space. Or I don't mind the kind of folding the mesh edges onto itself, since these are pretty lightweight meshes. So it's really not a problem if you double it up. So I'm just being a little anal here and just making sure the mesh has enough space. There, I think I was having a little trouble moving my left hand to the direction I want. I think the instrument was hitting the thigh, so I had my bedside assistant burp it towards the sky to move it away from the thigh. So you can see this reverse dissection is usually pretty straightforward. So now I have enough room to lay my mesh flat. And then you see the suture left from the fascial closure is right there. I left it kind of in the fascia, and all I have to do is drive it through, and now the mesh is pinned. With the Bard soft mesh, usually it sticks up a little bit better than the heavier, denser Parietine. So I'm just going to go around and place lots of 3.0 V-Lock 180s. Um, I would say for a piece of mesh that's about 15 by 15, I just put it in four corners. This one, because it's a little over 20 centimeters, I'm going to place a few more. Um, so definitely the four corners, and then kind of between the four corners. So at least three on each side. Um, I also place a mesh right in the center where the incision is, just to pin the mesh also in the center. I do not sew the mesh in the midline at the edges where the diastasis is, because I don't want the suture to rip through and cause a new hernia. So that's always been the Achilles heel of all the prior repair techniques, where we have to rely on fixation circumferentially around the mesh, such as an intraperitoneal onlay mesh or IPOM repair. I frequently see new hernias form at the 12 o'clock position, where tacks or transfascial sutures are placed through the diastatic linea alba. So, of course, with the robot, it's very easy to suture on the ceiling. So just several interrupted 3.0 vicals with 3 throws is usually enough. I just don't want this. I do all these throws just because with this space, as we desufflate, it's impossible. You know, we can't see what the mesh is doing, and I'm afraid the mesh is going to curl or fold or do something unpredictable. And so by securing it like this, I know that all the edges will stay in place, and as I'm desufflating, it's not going to curl and then under uh, cover one edge. And this mesh is sewn in usually with the pressure somewhere in the middle, probably 10 or 11. At 15, I think the mesh is going to be a little too loose. And at 5, I think it's going to be too taut. So I go somewhere between um, 10 and 11. And I see a lot of surgeons use ProGrip, which is probably okay. Um, but I don't use it for two reasons. One is um, there's a possibility that ProGrip is, because it's lighter, it's more likely to fracture, especially in these overweight patients. Polyester, may crystallize and become more brittle with time, and so maybe the recurrence rate will be a little higher. And then, ProGrip really doesn't stick to the posterior rectus sheath. Like when I place it in this situation, in this pocket up against the posterior rectus sheath, it really doesn't stick up to the posterior rectus sheath. So the Velcros really aren't helping me, and the mesh is much more expensive. So I really only see downsides to using ProGrip. Also, deployment's not as easy too, right? Because the grips stick together and make it harder to deploy it. So I ran out of suture, got some new sutures. I cut that O V-lock that was pinning the mesh and gave it back to my assistant, so it's out of the belly. I did bring in a 3.0 V-lock 180 9-inch so that I could close the fascia without any more uh, needle exchanges. And so you can see I just want this mesh to lay flat against the ceiling and not really go anywhere. It's not too difficult sewing these points in. So it looks like I did 3 points in the center and then maybe 3 or 4 points along each lateral edge. And I try not to get really deep bites of the posterior sheath so I don't injure the inferior epigastrix. And that's it. Um, so thank you for watching. In part 4, I'm going to show flap closure and evacuation of the CO2 from the pocket, which is probably the most exciting part of the surgery. So stay tuned.